I just wanted to start by saying I poured into the comments this morning that you've sent from the last meeting, since the last meeting, and I'm really pleased with them. They're getting more specific, more to the point, more actionable, and like where they're heading in general. So thanks to our conversation today. We have some process experts today who are going to help us take all of those ideas and take another crack at them in groups and process through some of them and get us to another level of detail. Let's see, I think we're going to just stick with the nameplates that are in front of us in terms of who's on the task force. We have some guests today, though. I just want to make sure we know who's here in the back. If you could each introduce yourselves.
Benson Washington, Rail Health.
Dave Gazelle, Fairview Health Services.
Matt Freeman, Association of Minnesota Counties Policy Analyst and Minnesota Association of County Social Service Administrators, Executive Director.
Lonnie Albright, boss.
Thank you very much. So we've got a lot of staff over here that are going to help facilitate our meeting. One thing our staff suggested after the last meeting was a reminder that today's meeting is being recorded. The recording and materials used or shared will be made available to the public, and subsequent disclosure may be beyond the control of DHS. Your continued involvement in today's meeting provides authority necessary for us to collect and maintain the data and make it available to the public. In case you're wondering where all that came from, we want to be careful about specific examples that are too specific and potentially disclosing private health information, for example. So just do remember that while we're sitting here, we're looking at each other. This is a public and recorded meeting, and we want to be careful about those precise examples. I wanted to share just some information to get started on some other work that's going on at the same time as the task force. We are about to kick off the hospital decompression task force, which also came out of the last session of the legislature. And in the meantime, I will share that we have said many times to a casual group that's been talking about this for a year, that the hospital decompression issue is no one person in the community's job description to fix. I have to say that our Natasha Mers, our Assistant Commissioner for Aging and Disability Services, has taken it on. And so now I'm calling her Aging, Disability, and Acute Transitions Assistant Commissioner. She's pulled some staff together from Moving Home Minnesota. She's pulled together some funding from Moving Home and from the Whatever It Takes Fund. Some of you may have used that in the past, and some ARPA dollars that were still available. And pull together a fund that's fairly flexible for use. And we've had a couple conversations in the last week with several group home providers who are able and willing to take folks out of hospitals. And we said, okay, and what's keeping you from doing that? And they told us some of the barriers. And so we're trying to look at ways to apply this fairly flexible funding to things like remodeling homes, just prepping staff, hiring and training, and a variety of things that would allow providers to indeed step up to the plate and take folks from our hospitals. One thing I'll just share is that I told them at the end of the meeting, I started at Lutheran Social Service almost 20 years ago when the group homes were filled with people with Down syndrome and cerebral palsy. And the population has changed considerably in those 20 years. And I was delighted that the folks were not talking about what they would have to have in order to begin to serve high acuity patients. They were talking about how they served the last 10. And so they're developing some real expertise and capability in that area. And we found several providers willing to take a look. So now we're developing a very specific tracking sheet of patients that need to find places in community and the providers willing to serve, and finding matchups and seeing if that funding we have might be helpful. And of course, what we found just looking around was not tons of money. And so probably preparing a proposal for session to add to that so we can continue to get folks moving. We're hoping that if we could get some folks that ended up stuck after the pandemic moving, that the hospital systems would start flowing again. We'll see. They might fill right up again with more stuck people. I have no idea. but we'll see how that goes. So just wanted you to know that that's going on, and the hospital decompression task force begins shortly, and they'll be discussing some of these same issues, but from that angle of hospital decompression. The other thing I just wanted to share is that DCT is in conversation with the governor's office about new proposals for capacity at DCT. A couple of things that you may or may not have heard about is we have decided not to build an SUD facility in Wilmer, which was really in the plan, but to move the staff as well as they are willing and able to our children and adolescent behavioral health hospital in Wilmer, which will open up capacity there. And I'm very proud of our group home part of DCT, who has purchased an apartment building and is planning to move some folks who don't need our intensive daily care to that, to live in a more integrated setting and community using the new integrated community services waiver, opening up space in our group homes. And so we've done a couple of things where DCT is already opening up capacity, and we're talking with the governor's office about what may be possible in this non-budget session to continue to add capacity in DCT. So I wanted you to know that state is looking at going first, not asking everyone else in the community to solve the problem. But those conversations are also going on. So FYI, any comments or questions about that? All right. So wanted you to know about those things. One of the things that we've been talking about a little bit in the comments that we've been getting is that we really need to be sure that when we're finished with the task force, the final report reflects the charter we were given, which is about priority admissions to direct care and treatment. And I really like the comments, as I mentioned, that are getting more precise and specific all the time. But we do want to be careful as a task force not to be trying to solve the entire behavioral health capacity question in Minnesota, but to focus on priority admissions for direct care and treatment, which is the charge of the task force. So if you could keep that in mind today, we would appreciate that. Do you have anything?
Yeah, I'll only add that I think some of the broader conversation and suggestions and analysis to the larger issue of how to have a better behavioral health system are important and have a place and provide context. So I just want to be clear that these are welcome ideas, but the legislature does want us to be kind of focused on the task we were given. But beyond that, I think that I think we're on course, and I'm looking forward to have a product that we could move forward from the legislative standpoint that meets the needs of the problem and has to consider judgment of everybody here.
Let's see. Then I'd like to introduce Tara, who is our quality director for DCT, and Stephanie Louis, our quality director for MSATs. Now you guys are going to have to tell everybody what that stands for. Mental substance abuse treatment. Thank you. We use a lot of acronyms, TCT, who are going to help us with our discussion of the comments that you sent in so far.
Up you go. Good afternoon. This portion is going to be a little interactive, so this would be your time to load up on beverages or use the restroom or something as we start to transition to the next phase. We're going to be up and kind of working through some grouping and some analysis as a team. So we'll go from there. So as the commissioner mentioned, my name is Tara Carey. I'm the Chief Quality Officer for Direct Care and Treatment. Stephanie View also works in our agency supporting primarily the hospital service line, along with the chemical dependency and MSHS, so the mid-level specialty service organization. We had a chance to go through everybody's feedback, so thank you for those who had a chance to do that. We are going to hand these back to individuals with two asks. One is take a look at your handout and just make sure it's accurate, okay? And then go through and number your Post-it notes. You'll get as many Post-it notes as you had in responses. Did you do the same thing? Beautiful. Do you want to hand them off? Here. You can do it. And so just go through, number them, and just reorientate yourself to your responses. We'll give folks a few minutes on that, and then we will all get up and start kind of looking through a few things. You also should have received a draft qualitative analysis that was done with the feedback. It was difficult to parse through what everybody intended with every response, because often, as you'll notice, things overlap, right? So it's funding tied to capacity, tied to policy. So how do you group that specifically into one category? We just gave it a beginning preliminary analysis to get our initial buckets. We'll be asking you all to help us categorize them as we move through this exercise.
Can I ask you asked us to number them. What is the numbering?
Some of you have numbers on your responses. So like 1 through 15, for example.
So ranking, is that your
Nope.
numbering?
Nope, not ranking necessarily. Some of you. You didn't do it. Some people did 1, 2, 3, 4, just so you remember which post-it notice for which. You could, if you didn't number it, just make a little note. What each one is, for the 48-hour rule, capacity, DHS, because you're going to categorize them on boards.
I'm still not sure why we're numbering them.
So that you can track it as you group them up. I just want you to be able to make sure you're accounting for all of your thoughts
Okay.
as you go forward. If you can do that, that's awesome.
Okay.
So if you have 8, you want them to account for it.
Yep.
Otherwise, you have to put your whole ID on this teeny little small circle. You have it, so. Not the post, your village.
Questions? Please, you have a comment. Okay.
4 of us. We did the choice.
Yes, yours I wasn't quite sure about, so you have the joint with 4 groups. You will be the same. Let's make sure we count for the 4 feedback then to weight it 4 times. So we'll give you 4 more groups that you can post it.
Well, they're here.
We each have.
Oh. Okay, do you each have the same report?
Yes.
And
It
you each
should
have
be redundant. Is what I-
Got it. Yeah.
Well, I'll take.
Okay. I didn't understand.
Just amplify or make sure our voices are.
Yeah,
right.
that's the point. I just want to make sure everybody is
Fine.
heard right. Yep. I've never met you, so I think that would be true. Oh, and Dr. Hard is not here. Is there somebody who is comfortable filling in for her? We two could work together and she. You got it. You're not working.
You want us to put our name on the post-it note?
I want to make the exercise, the intention is that everybody understands that their votes are getting put up and they're able to track if they decide they want to recategorize some things.
Okay.
So if you can do it.
So you want us to put our ideas on post-it notes and put the post-it notes on the.
We'll walk you through that.
Okay,
Just start right now with putting your ideas on a post-it notes.
so kind of like transcribe this stuff onto.
That's
very
very
separate.
to your number. That's one of your.
Okay. So, should I put my name on it or no? I'm just trying to follow it, right?
You just have to be able to track your vote.
Okay,
As long as you can track it, you can put a smiley face, a heart, and then
okay.
keep it anonymous, whatever you choose.
Following you.
So we thank you for doing this. And now we're going to move on to the next step of the analysis as a group. So if folks remember, this task force was statutorily tasked with really 2 unique areas of work. One being how to focus in on the priority admissions for direct care and treatment, right? The second part of how to enhance or build out treatment for folks in the community while they're waiting for admission into direct care and treatment. And so what we'll do today is really just focus on the priority admission. Everything else will still maintain the information that'll just be used for the next analysis for the next part of the report or wherever this information is. Okay. So when we look through the groupings or buckets, we come up with these things. And so we'll end up removing the Post-its, the large post papers that are not directly tied to these 3 things or this area. So Bed capacity at DCT will stay, admission to a DCT facility will stay, right level of care at the right time will stay. Improving programming and treatment changes will stay, workforce and staff development. Again, not everything will be directly tied to direct care and treatment, but they're applicable areas of review. Statutory modifications, mental health infrastructure, changes to competency restoration, changes to the forensics mental health program, changes to the internal DCT processes, and then funding. Okay, so we'll remove everything else. Does anybody have concerns with any of the things we're going to start taking away? So we will take away, the first one we'll take away will be mental health, oh, we're gonna start down there. You pick,
Give us a second.
just make you walk all over. We're going to first remove the mental health treatment in the jail settings or not. Concerns with that as a group
For the next half hour, not from our final report.
for the next half hour, not from the final report. Concerns.
What we had talked about I would say had direct linkage to priority admission, because it could in fact change an individual's status within the priority admission.
So if it was going to be priority admission or related to admissions, it would have been categorized in the admissions to the GCT, not under the treatment and jail center.
No, but it can prevent.
Yes,
someone being in
everything is very interconnected,
Right.
but we need to start analyzing and tackling this in one capacity.
So should we move our stuff that would relate?
We're not gonna move things. I mean, I understand that there's concern. We're just gonna move it to the side for now. We'll analyze more as we keep going. Okay? Of course, it's not gonna go away. We're just moving it for this purpose. The next one is going to be community services, non-direct care and treatment operations. We'll take that one down. Because again, we're done focusing on DCT priority admissions. Community mental health crisis management, take that one down. Physical plant infrastructure, maybe. Then other.
We'll hear that.
Okay. So now we go through these and we look and essentially count out how many ideas were applied to each of the buckets. I think it's pretty clear if we look through number one with you funding. Right? Does anybody have a different idea that funding didn't receive the most number of ideas?
All I'll say about funding, not just funding, it's funding for certain things.
Yep.
Including community.
And that was for sure in, the statute was clearly outlining that if there was funding, where it would be most impactful. That was the ask of the task force.
Okay, so I'm sorry, because I'm not understanding this process at all, because even if funding got the most votes, what it's funding for is so different across the board that if we're trying to create consensus, it would depend on what that each individual funding piece would be.
We talked about when we did our post-class, when we try to decide if you're funding workforce, do you put it on workforce, do you put it on funding? And if you're funding physical, you put it there, you put it on funding. So a lot of stuff funded under funding.
And that's, I mean, honestly, as everybody who's worked in this field for a while knows how interconnected everything is, right? I mean, mental health as a whole is very connected to community and treatment and access to medications and all of the things, right? And so this methodology starts to get us to a place where we can start identifying a couple of things to make recommendations for collective.
You could have all these things just for the funding.
Oh, for sure. They all, I mean, anything could end up being a statute modification, but then if you don't have funding for it, it's not deployable, right? Okay, so funding came out with the top number of votes. What is next?
All the better.
All permissions.
So for the purposes of just our time together, because we do have a finite number of minutes together, let's just start with picking the top 3 groups, the areas that receive the top 3 votes, which it looks like will be funding and missions. Does somebody feel strongly or thought that we should also ask workforce? At 11.
Got the same number.
11. Do we want to add workforce? Do we have 4 groups? Do we want to have 4 or 3 today? 4. 4. Okay, great. Yeah.
And yeah, these are going to be.
There's no reason we can move them against the stick again. Okay. So this is now where we break up into smaller groups and start working on our specific areas, okay? And so, let's try to remember how to we'll start grouping them together. Okay. Okay, so I'll take funding and workforce. So if you want to take initiative, the records. So you guys can pick 1 or 2 of the groups to come to, or actually 1. Either staff or myself, and we'll work through it.
Come back together, please.
That was when I was struggling.
If we could come back together.
Yeah.
I mean. Right, there's 3 dollars. Yeah. Yeah, okay. I'm not gonna go on that.
Hey,
I've been thinking about all those complicated projects that I've been involved in the past. They tell us they start with diverging, and over time we start to converge. And I think today we're starting to converge. We're trying to get closer to something specific that can go in our final report. So appreciate the efforts. It's messy when you're starting to get to that stage, so appreciate you hanging in there today with conversation. And can I just summarize what we heard from the 2 different?
so our group had workforce and funding. We quickly realized that for a lot of parts of funding, we would be remiss if we stayed really internal to DCT's work. And so we also expanded to include community services. Knowing that community integration is really an important part of the work that we do. Our group did ranking, so we grouped each of the topics back, and then we ranked them for inclusion. So the first funding was reinvesting DNMC monies back from the general fund. A recommendation would be to reinvest from the general fund back into mental health or substance abuse treatment in Minnesota. And then there were another handful of recommendations here to improve funding options for. So some sort of track or psychiatric kind of ICU within community hospitals. So fund specifically something along that lines, the 1115 waiver, various components of that, but funding that. Fund some sort of program that would support Jarvis within the jails. I realize we didn't have the sheriff over here on this side, so we're open to continue the discussion.
That's good.
Funding IRTs within the community is both locked and unlocked. Generally funding county resources, not taking taking monies from counties, funding counties to provide mental health services. ACT teams, innovative and supportive housing models. An option for flex funding, so an allotment of money to be used for urgent to emergent issues or as determined to be needed. And then some funding for voluntary engagement for folks back into systems. So specific funding across the spectrum services, and then from a workforce perspective, we both thought these apply to DCT and to the community. So pay, generally speaking, some sort of option for supporting providers, so preventing burnout, wellness, and retention. Specific training for mental illness and substance abuse, so de-escalation being one that was talked about, but motivational interviewing, trauma-informed care, et cetera, within the community. And then building out the general substance abuse treatment, mental illness, professional trainings, kind of ladders, and thinking of that workforce a little bit more robustly and using some natural strengths that the state has. So those were the areas that we took, I think, 3 pages of ideas and condensed them down to us. The other area followed more of a root cause analysis process, a little bit more getting into the causation of issues. I don't know, Steph, we didn't really talk. Are you able
Yeah,
to
we
share?
came up with three problem statements. The first one for the DCT bed capacity. We said, there's the lack of bed capacity and bed category. Categories for long-term treatment for people at high acuity, or chronically ill, is resulting in harm. So if you have an increased likelihood that we're not meeting demand, resulting in harm. The second problem statement that we came up with regarding more generally about bed capacity, but more on the community side, there was lack of facilities and services for high acuity chronically ill people being discharged to the community, increasing the likelihood of safety concerns and decreasing the likelihood that their individual rights to be treated in the least restrictive setting occurs. And then the third problem statement that we came up with is bed placement is not based on clinical need and individual circumstances, but rather physical location, what list they land on, the ability to only be on one list, legal status, and the ability or skill set to communicate the patient case.
I feel like we should clap that. It's a lot of reflection.
A lot.
Because really did a lot of work today.
Thank you. Thanks for letting us.
Well, back to the beginning, I said that the responses this time around were getting more precise and converging on some solutions. And so thank you for that. And then had a chance to just mull it over and talk about them and debate, discuss them today. It's another rich opportunity. So appreciate everybody's attention to that. As one of our next steps, we were discussing just process-wise, how to get from here to our final report, and we're thinking that it would be time to draft a report and start working off a draft report until it becomes our final report. And we've asked a few of you to help us with that. So we've wondered if Kevin would help us with that, and Sue and Dr. Corona. So appreciate that, and we'll talk about how we do that, how we go about that, and what are steps A, B, C, 1, 2, 3, to drafting something and getting your inputs, and then coming back to this group with that, and then we would start to talk about that document piece, we're trying to get closer to a report from the task force. Thoughts about that? Comments, suggestions, advice?
I'm wondering how the subgroup will get input from others. So for example, Kevin's fabulous and there are significant chunks that he knows lots about.
A lot I don't.
Angie knows broad and deep in a way that Kevin and Brian, I don't know on a number of issues. So Kevin is a great person to have in there. So yeah. And how do we make sure that that if somebody else wants to give it in along the way, or that you use it as subject matter experts. I'm not gonna pretend to be the subject matter expert.
Yeah, so all we're gonna do is a draft to bring it right back here. We'll have a chance to talk about it as a whole task force. I know you've been working together behind the scenes, I would expect you to be doing that.
So I lobbied for another, person who was more, but I mean, there's some other expertise on there, and then I think the idea was that my input would be, collaborative, I think as with other drafters. So it's not, we're gonna sit in a room and write it out, we'll have the opportunity to collaborate in the drafting process, right? That's kind of the thought.
I would guess that our staff here would write the first draft and get feedback from folks from the task force and bring it right back to the task force.
Yeah, or maybe start with some guidance from the group and do the initial drafts. We can talk about that, but
And the way I see it, Kevin, is that's what this is all about. You guys are not drafting in a vacuum. This is all based on all the stuff we've been talking about. I'm thinking you're gonna take this, somehow put it in a narrative form. Then some of the folks that Jody mentioned are gonna sort of like, fill in the blanks, take out the stuff that we have plenty of. Then we're gonna come right back here and everybody's gonna go through input, all that. The only reason I like what you proposed, because I just think we got a too many cooks problem unless we get a few people who are going to wordsmith it out. And so I'm cool with the proposal. Thank you all for being willing to do it.
I recommended, agree that we have some kind of open, document. So if there's multiple drafts between times when people are reviewing it, that's accessible people. So you don't get like a 3/4 baked draft that you then are trying to edit when you disagree with, half of it, right? So I think it's collaborative all around.
And I think we deal with disagreements if and when they come up. But with that, we have an eye towards coming together, just from a legislative standpoint, and, Tony spent time in the legislature too. I mean, it's better if we say, look, we come from a broad cross section and here's what we think would help. Rather than we have, 25 different points of view. Because the legislature then is just left with picking the one they, and they're gonna do what they want to do anyway, by the way. But I think if we could come to some consensus based on the experience, it's a good thing. Have some specific recs, recommendations based on our input. That's what I hope to do.
And we still have all of your responses, so the group of drafting would go back to this and ask if they missed something that somebody offered. Consideration by the whole task force, not just our own opinions and. We want to do that. We have another meeting scheduled.
Not yet, and so I think we left it open-ended.
We've been meeting about once a month.
We could figure out that day. Be really great if we could figure out what that date is and get another calendar.
And in terms of dates, I think Terrell's right. It'd be great to get a good date. Another thing is I think we should try to think about when we want to have a finished product. And then reverse engineer so that we're ready. So that the legislators who look at this are gonna be able to digest it. And then we maybe could get something moved in the upcoming session. When does this session start? Is it like February?
Yeah, there's an actual due date in the statute. Is it February 1st or?
I know, I have it on the calendar.
It'd be great not to go right to the
Yeah,
end.
no, we should be working on final. So,
Yeah.
That session starts around Valentine's Day.
How does that work? Do you guys have to
It's 12.
present?
February 12th.
12, I'm hearing 12. Tony says 12. Yeah.
So basically, we've got 2 months to get most people drafted, right?
Are we writing statute too? To accompany the report?
Maybe. You see what we come up with.
That takes some time.
Yeah. In the conveyance.
Mm-hmm. Maybe.
Well, you got the revisor who can help with that. but it would be good to give them as much direction as possible.
I think that our mandate, right, is to do a report. I think that's the first thing to focus on. If we could translate that into a statute, we agree on it, right?
Yeah.
We better get the draft done.
Yeah.
That's another whole level of language. But, yeah, no, it makes sense if we have an opportunity this session.
And we might not get the statute done by the same deadline as the report, just because we're looking at 2 months and then taking the report and putting it into that completely different language. So,
That's right, but I will tell you this, if this group comes up with some good ideas that are actionable, I believe the legislative session will say, look, this was such a controversial thing last time. Let's try to get something done that we can all agree on this time. You know, nobody wants to relive, the controversial situation. So there, if we can come to some agreement, I think that they would move it up the list.
absolutely.
Yeah.
There's definitely an opportunity.
I also, I just wanted to, if I could, I'm a little reluctant to put this in at this point in the meeting, but, I've come across some data recently and I just wanted to share it with the group if I could, so we're level setting. I understand from our DCT people now have 173 hospital patients. Right now, we have 98 patients with jails civilly committed to DCT and on a wait list for priority admission. And the way the current priority admissions rule is stated, we would be doing jails, 173 people before we get to hospital. And so what we've been having a conversation about. Like that. It's how my brain categorizes rapidly. And so that's some of the same kind of language has come out on some of these diesel sheets and some of your stuff that you submitted ahead of time, suggesting that we need to also be thinking about hospitals right now and in addition to the jails. So I just wanted to share that data with you. Because at this point, people civilly committed to DCT and in a hospital will almost certainly not ever get through the wait list and get into DCT. So I just wanted to share that. And want to talk about potential solutions to that, but don't flip it around so that everyone's coming from hospitals and no one's coming from jails. We're not talking about that, but how can we blend those so that makes more sense for the whole?
Commissioner, those many people are on the wait list. You can't add that many beds to DCT. And so what that really means is we really do have to start looking at the community and what we can, develop to send people there, because you're never going to get that many beds. And so just, and then people are far away from home on top of it. So while I know that the report is supposed to focus on priority admissions, we can't solve it unless we also look at building the community. That's a lot of people.
I think I completely agrees with that. I mean, it's about expanding the capacity so that your demonstration doesn't end there and everybody else just sits in the hospital or the jail. But whether they go to DCT or they go to a appropriate community facility, that they're out of both of those settings as soon as possible, right? We agree on that.
Any other thoughts, observations about our current situation? Problem to be solved for sure. So I hope that as we continue to draft our report and look at solutions, that it starts to deal with.
I have a question on the data. Is that for all DCT facilities or just AMRTC?
This is all.
All, okay. So individuals from hospitals can get into DCT facilities, just not some. So you are admitting people from hospitals, just not, it's the security needs that, and the legal needs that kind of bring us into that picture.
Right, and the economy of scale that the larger facilities afford in terms of multiple staff to respond to things, et cetera.
Right.
Physical plan.
I wanted to make sure that I was understanding it correctly.
Just to show you that. So at AMRTC, there are 51 people civilly committed and on the wait list from hospitals, 59 civilly committed and on the wait list from jails. And our forensic hospital in St. Peter's, 6 from hospitals, 27 from jails.
I assume that that number does not include access for children and adolescents.
The total level would, in terms of our child and adolescent. mental health. But not committed on the right, am I saying that right?
I believe CAB is included in the hospital referrals. Marshall's saying yes. Okay,
For not just committed.
not just committed.
And CBHH is not,
CBHH is on there.
it is.
On
Part of the
total.
larger total. Got it.
On the left, yeah. That's the name for this task force. So,
Yeah, question, Commissioner. Unless someone else did. So we'll come back together in about a month. I'm wondering if what the group would like to discuss at that point. Is it fleshing these ideas out further? Is it addressing some of the stickies that we didn't get to? I wonder if Tara and staff have suggestions for how to go about those unexplored items.
and I would hope it would be a draft report.
Mhm.
See if we're close, well, a million miles on.
I think we know those things under the corner.
Yeah.
Certainly analysis was recommended. So you may not have consensus fully, but how many words?
And maybe there's a way to prioritize before we're done, which of our ideas deserve bill language, because they're that close to being crafted that we should just write them in. Cross that bridge. Any other thoughts at all about the issue we're dealing with?
I have another question or thought. Because when I think about this problem, it's really hard to separate all these components. He keeps asking about discharges and the impact it would have. We have a task force looking at hospital decompression. There was a task force looking at competency restoration. So it's hard for me to kind of wrap my head around this without understanding where these things fit in and what impact they have. So maybe that's just my personal need to understand. Because frankly, it just kind of feels disjointed and still so related.
We should I think we should probably do an analysis of where we're at with hospital decompression and the competency restoration task force and this one, as we're finishing our reports, make sure we're adding some.
I'd love to talk about the report and drafting next time, but I'd also like to spend some quality time talking about discharge.
DCT.
Yeah, because if we don't, we're filling up, but we're not moving on. And so I'd like to drill down on that, get some quality conversation on that.
And frankly, I forgot to mention at the beginning of the meeting that as we talk to providers in the community about taking people out of jails and hospitals, or out of hospitals especially, we're also talking about taking them out of DCT. Because it's actually possible that some of the community providers will be in better position to take people who've been in the care of DCT into their facilities than right out of the hospitals. That's part of that conversation.
Is it safe to assume that somebody who's been through a DCT process and has been discharged based on the normal rules might be in better position to sort of like acclimate to community setting than somebody who's just fresh out of a jail or hospital?
I don't think you can say that, no.
Okay, fair enough.
I think that's what you would hope,
Okay,
but that really requires that there be the right place for them to be and get the services they need in the community. So for all of us, the question is, you can do whatever you want acutely to manage people, but if there is no appropriate care, once people walk out the door, it's frustrating, it's somewhat futile.
You think about it from a risk assessment point of view, there's factors that can change, and then there's the long-term risk factors. And I think the long-term risk factors are certainly the same or similar across settings. Mitigating those short-term risk factors is the big thing, and that's why the transition out is so important from any setting.
and the other thing I'm wondering about, and this is in the discharge conversation, what kind of workforce needs do we have in terms of the discharge, and where are we? So for example, I'm assuming you need some psychiatrists, like, you need those kind of folks who got a lot of schooling. And you might also need some people who may not need as much training, but just who are good at caring for others. Where are we, what's our deficit? What's our delta gap in terms of workforce requirement?
It's huge.
That's right.
And there's several reports that have been out there, over the years. And, we have a lot of people who actually graduate and don't get licensed. And so those are barriers there that we've tried to address over time. But we know, particularly with psychologists and psychiatrists, just huge shortages.
Good choice.
Yeah, and then I would also say diversity. So about maybe 15% at the most of our kind of licensed like social workers and LPCCs are people of color. So almost everyone is white.
Yeah.
Which also doesn't help.
And I would say the patient population is far more diverse than that.
The overwhelming thing to me is that I think the need is across the board. Whereas I will tell you that the restrictions in terms of the number of beds I have open at times is based on whether you can have nursing staff or mental health workers to take care of patients.
Yeah.
And by the same token, I turn away 300 phone calls a month in my outpatient clinic. And if I had enough providers, I could probably serve a bigger portion of the community. But I can't do that if I can't hire a medical assistant or somebody at the desk.
Right.
And you're having a lot of entry-level people coming into nursing or mental health workers who are abandoning it very quickly because of the high rates of assault, the lack of security, or the acuity struggle somewhere happens. So it's an overwhelming large problem. So I get kind of more anxious the more we talk about it.
Doc, I don't want to drive up your anxiety.
Yeah, that's okay.
But I do want to ask you this, when it comes to some of the people who don't need medical degrees and other kind of stuff like that, is their pay like PCA pay? What is it? Is it a low income sector?
Very much.
Okay,
Some of the providers we've been talking to who said they'd be willing to take folks out of these settings and paying over $20 an hour.
okay, so that's better.
Frontline.
But still, I would imagine is that the top scale or middle or? Okay.
That's kind of a rarity. That's also not the norm. I think up to 20 is kind of where we're at if you can afford to pay unlicensed folks that much. On average, we're probably closer to between $11 and $15
Right.
an hour. And I think, you've all probably heard a lot of this too. Our competitors now are not even other mental health or healthcare facilities. Starbucks, Caribou,
Right.
Quick Trip are paying $21 an hour plus.
And you don't usually don't have.
Without having to dodge and duck and,
And go through a lot of
Yeah.
schooling, and even our licensed professionals, if you compare what our licensed professionals get paid compared to other medical licensed professionals, it's very much on the lower end of the scale. So there's also a lack of parity across our, what we call healthcare medical field in terms of how we pay our SUD and mental health professionals.
Dental hygienists make more than a licensed clinical social worker.
All right. Well, thank you again for your time today, for your ideas ahead of the meeting, and stay tuned for draft reports to be for the next meeting.
thanks everyone. Thank you.